All right. Hello and good evening. I am delighted to be here with you guys tonight to present my final paper for healthcare policy, and I'm excited to do so. So I will dive right in and share my slides here with you. All right, and open it up into presentation mode. So here we are. The title of my paper is the International Classification of Disease Policy Change, also known as ICD codes. My name is Clayton Herring. I am a student at Baker University, and this is for our HCA 380 or 530 Healthcare and Policy and Politics. Dr. Clarice Powers is our professor, and the date is July 26, 2020. So the first thing to understand is what are ICD codes. So there's been a long history of ICD codes, which are outlined in my paper, but the most important question to answer is what are they? So they're a tool that's used to decide what the epidemiology, the health management, or clinical purposes of a clinical diagnosis are. It's used for medical codes for nurses, researchers, healthcare workers, and all array of people who work in healthcare. And really, the main purpose of it is to put into one single language for clear communication what somebody's diagnosis is. And it works, and it's helpful to understand. Um, it is international, so somebody in a different country can have a diagnosis of cardiomyopathy, and we can understand in a different country exactly what that means and how to treat that. And then it's finally also used for payment and for billers. So without using that code, you cannot be properly reimbursed, especially by Medicare and Medicaid, and most private insurances require an ICD code to be tied to any kind of treatment that's given. So that leads me right into the next point of this is about ICD codes and about changing the policy for ICD codes, but why are we talking about CPT codes? That's part of my paper as well. Well, the biggest reason is because they're usually tied together, and you have to have an ICD code in order to be reimbursed for the procedure that you're doing or the current procedural terminology, your CPT code. So the reason that this is important to understand is that you can have a patient who really needs to have a procedure done or needs to have a specific visit with a physician done, but it can be hard to tie an ICD code to that. And that is going to be the reason for my policy change. We'll get into that in a minute. But both codes are required for pre-approval of procedures. And that is where my presentation and my policy change really start to take effect and become important. So what's the problem? So patients are forced to make difficult decisions. What do I mean by that? So let me paint a picture for you about what might happen in the facility I work in. So I work in cardiology and GI, highly procedural, sometimes elective, sometimes necessary procedures. And even the elective ones are important for somebody's health, such as a colonoscopy may diagnose cancer, or such as a heart cath may diagnose coronary artery disease. But let's just say that one of those people come into the facility and they need to have a procedure done, and the physician's office has set them up for this procedure. And they walk in, and the physician office got them pre-approved, but the facility, rightfully so, does a second approval through the Medicare website. They come up as not approved. So the provider is now, and staff are rushing to find an appropriate diagnosis that will get this person approved. And sometimes it just can't be found or known, and it takes a lot of extra time. So that patient is forced with this decision to make of I either sign this piece of paper that this procedure could cost me hundreds of thousands of dollars out of my pocket. It's probably a little bit of an exaggeration, but probably about $50,000 out of my pocket for certain procedures. And or I can wait, and my doctor says I really need to have this procedure done. Or I can just hope that the system all works itself out. I know I need this procedure, and all will be okay. Well, we've already added a lot of anxiety, a lot of concern, a lot of worry to this patient. So it's a scary and difficult situation to be in. Another reason, another problem is potential fraud. So in that scenario that I just described, imagine a provider knowing that this patient needs this, and he knows or she knows that, you know, in order to get that procedure, this code will work, even though that's not exactly what's going on with this patient, but I know this patient needs this procedure. So that physician might write that. And I would say that that's kind of an unintentional fraud. I mean, I think that a physician is wise enough to know that they're creating fraud in that situation, but also they're just doing it because they know their patient needs the procedure. There's the other kind of fraud where they're doing that on purpose, or they're making it look a lot worse than it actually is in order to get paid more. And that's not the kind of fraud I'm talking about right now. And then, obviously there's the fear that patient just may not receive that procedure out of fear, understandably so. And God forbid something happens to that patient for the reason that they were in the hospital. And then finally, it puts a lot more pressure on providers for reimbursement. Part of my paper talks about how providers are being forced to do a lot of this coding work in order to be reimbursed, and it's made it a lot more difficult on them. So let's talk about what some of the solutions are and my proposal for policy change. So my proposal is to have an exceptions committee. And I'm going to get into exactly who, what, and when that all happens and how that happens. But these people would be readily available, fast acting, real time, not the norm for our government healthcare. And they would make decisions on coverage. So that's all the why. That whole story before this is the why. Let's talk about who, when, where, and how. So these people, the who, would be subject matter experts in cardiology, urology, GI, orthopedics, oncology, radiology, neurology. They would be vetted by the US government. They would be available when the defined and easily applicable definitions did not pass approval. And then exceptions would be only accepted during normal business hours. So not going to be open 24 hours a day, but from 7 to 5, they would be open. Where would they be located? I think that there would have to be some kind of regional or state teams in order to handle the volume of requests. And that would take some figuring out, right? It would take, we would have to set up a mock, basically, to understand how many phone calls from facilities would we really be receiving. And then finally, it would be done by phone. Only specific personnel at each facility would have this number. My kind of ideas here are like your access coordinator or your admissions director, and like a CFO. Like those would be like your two people, maybe a COO in there who have the ability to make this phone call, because obviously we don't want the physicians' offices calling and registration personnel calling. It would have to be something that would have to climb a very specific ladder in order to get to that phone call. And then I think also a provider would have to be involved, because you're going to be talking some very clinical decisions. An example or an idea of how I see this happening, I'm very strong in cardiology, so I'm going to use the cardiology analogy is, patient comes in, they're supposed to get a pacemaker. And their ICD code is for sick sinus syndrome, meaning that their heart isn't beating at a normal rate. That can mean an array of different things, but it doesn't pass. And we can't find, let's say we put in bradycardia, that doesn't pass. We can't really find any ICD code that's applicable to that patient. But this patient needs to have a pacemaker put in, or something serious could happen to them. So my idea would be that the patient access coordinator, or the director of registration or access, would call this phone number. I mean, it's so simple, but simple doesn't always mean easy, right? They select cardiology as their need. It goes directly to the cardiologist that's on this staff, and cardiologist A from the facility, cardiologist B on the exceptions committee, and says, hey, here's my patient. Here's the situation. Here's some kind of code so that you're able to look at them. And I can share these files with you. They're reviewed, and within a short amount of time, they say, yes, this patient's approved to have this procedure done, knowing that their subject matter experts have made a decision that is equal to the physician that's wanting to implant. That physician and the staff didn't have to go nuts, and it gets taken care of, and that patient gets their pacemaker, and they're reimbursed appropriately for the service that was delivered. So who would support me in this? The association I selected was the Medicare Rights Center, founded in 1989. It's also called the Medicare Beneficiaries Defense Fund. A woman named Diane Archer started it. One of the first actions was a lawsuit towards the federal government for false Medicare explanation benefits. They failed to mention limits and what doctor may charge for a service, what beneficiaries may pay. It is a non-for-profit that works with older adults and people with disabilities. They offer counseling, advocacy, and educational programs and public policy initiatives. And their mission is to help people with Medicare and understand their rights and benefits, navigate the Medicare system, and secure quality health care that they deserve. So I would look forward to working with this association. I think that they would have very strong feelings towards what my feeling is, which is give people right and appropriate care, make it as easy as you can on the providers, and let's take care of people. These are my references from my paper. I have also submitted my paper. I appreciate your time. I appreciate this class. I appreciate everything that I've gotten from it and the feedback that I have received. All well wishes, and hope to see you in the future. Thank you.